notes of apricot and guava. Alright, in this video, we're going to learn together about how to spin the urine, and then how to interpret urine sediment findings, specifically different types of cells, different types of casts, and their clinical implications. Let's go.
Kidney bath topic.
Yo, let's take a quick tour of the urine microscopy room so you can visualize what it is that we do when we prepare a sample for urine sediment analysis. All right, we're going to take you over to this station here. The first thing you're going to do is when you have the PP in hand, you're going to pour about 7 to 9 milliliters into a tube such as this one, and then you're going to set your sample into the centrifuge with a conveniently located balance weight already applied inside. We lock it down, we kick it up to 3 or 4 minutes, and we let this bad boy go. And after that, you take a look at the urine, and you should see a little bit of sediment, a pellet that has come out, and I've used that Sharpie dot. Let's see if we can get focus on it to approximate the size of what a pellet might look like. So you're going to go into the sink and you're going to dump your supernatant out, and then you have usually a drop or two of urine that remains. You come over here using this pipette, you resuspend the pellet such that you get a nice even distribution gently without disrupting any of the casts that might be present. And then you're going to take just 1 or 2 drops of the urine in this pipette and come over here and put a sample right onto that slide, throw a cover slip on this bad boy, and you come over here to the microscope and you pop it in there to take a look at what you may see.
Cells, casts, and crystals. These are the 3 buckets of things that we're looking for when we inspect urine sediment underneath the microscope. Let's set the crystals aside and focus our attention specifically on cells and casts. Turning first to cells, there are 3 distinct flavors that we want to pay attention to: reds, whites, and rosé. Yes, that's a dumb joke, but you should check out Post Malone's 2020 French Rosé drop, Maison No. 9. The third cell type is renal tubule epithelial cells. Turning our attention first to the red blood cells, they're going to be the smallest, so they're going to clock in at 6 micrometers in diameter. They're not going to have any nucleus, and a monomorphic RBC is a nice circular shape, so it's easy to fixate on or anchor as a point of reference. If you see more than 3 to 5 RBCs in a high-power field, we will call that microscopic hematuria. Dysmorphic RBCs is when you have a disheveled or a disgruntled cell membrane of the RBC. Acanthocytes is a specific vocabulary word that we use for dysmorphic RBCs that have globules or corpuscles that sort of bleb off of the main cell membrane. They're often likened to Mickey Mouse ears. Disney Plus, get at me. If you have dysmorphic RBCs, those will be suggestive of a glomerular hematuria. That is to say that they will localize the lesion to the glomerulus. Second type of cell that we should be aware of is the WBC, or the white blood cell. There are different flavors of WBCs. You can have neutrophils, you can have eosinophils, and you could also have lymphocytes. The most common that we're going to see is going to be the neutrophil. So this is bigger than the RBC. It's going to clock in at about 10 to 15 micrometers. A couple of clinical correlates that we should get straight. So WBCs are not specific. They basically let you know that there's inflammation going on. Could be urinary tract infection, distal, like localized to the bladder, aka cystitis. Could be proximal infection, aka pyelonephritis. Could be acute interstitial nephritis. Could be any nonspecific sacropelvic inflammation that is causing irritation to the bladder. Second thing I'd like to say is I want to debunk the myth that eosinophiluria is specific for the diagnosis of acute interstitial nephritis. AIN is notoriously difficult to diagnose, and the presence of eosinophils in the urine isn't particularly sensitive or specific for a diagnosis of AIN. All right, last but not least, we have the renal tubule epithelial cells. These guys are the big papa of the bunch. They're going to clock in at about 20 to 30 micrometers. They can have different shapes, so they could be circular or more oval or even polygonal. In terms of their nucleus, it's usually a single nucleus, like a single lobe that might be a little bit askew or off-center. Now, the renal tubule epithelial cells, if seen under high microscopy, would be suggestive of an acute tubular injury, and that's their clinical significance. All right. So now let's move on and talk a bit about casts. Casts inherently are going to have a cylindrical shape, and that's because they're being sort of formed and squished in the tubule of the nephron. They can be short or tall, skinny or grand in girth. There's going to be this protein, it's called uromodulin. It is made by the renal tubule epithelial cells. It's a glycoprotein. And this protein is essentially the skeletal matrix or background of all casts. The simplest of the cast is the hyaline cast, a cylindrical silhouette of sorts. It's basically a ghost cast that just has the outline of a cylinder and is essentially just the uromodulin. It can be suggestive of a pre-renal acute kidney injury that might correlate with sluggish urinary flow. Now, if there are granules inside of that cast, aka lysosomes, which is an organelle, then we might call it a granular cast. And if there's superimposed brown pigment in that cast, then we would call that a muddy brown cast. So granular casts and muddy brown casts are often indicative of acute tubular necrosis. You can have red blood cell casts in which some red blood cells have been trapped inside of that glycoprotein uromodulin matrix. Classically, we like to think of this as another clue of a glomerular hematuria. And then you could have white cells inside of that cast matrix, and we would call that a WBC cast. Again, same teaching point as with the WBCs themselves. WBC casts are not particularly sensitive or specific for anything but inflammation. So those are examples of different casts that we might see. All right, almost there. I want to finish up with a core concept, which is the following. When we're talking about analyzing urine sediment, it's important to remember that any findings with the analysis of said sediment must be clinically contextualized. Another way to say that is if you see a particular cast underneath the microscope, that cast will never be perfectly sensitive or specific for a particular diagnosis. Take a look at the summary slide, and I'll catch you in the next video. In support of the blood urea nitrogen, I've been growing out a man bun. If you'd like to support me in this endeavor, please like, subscribe, and consider watching perhaps this guy or this guy. I really appreciate your support.